Okay, we have a case sent to us to evaluate for immediate placement on tooth number 18. The first question, obviously, many people ask is why is this tooth being taken out? And not my case, but it's being sent to us. But what I'm seeing is probably a root fracture or significant periapical loss right here on the distal bone here. And then I don't know the condition of the rest of the tooth, uh, but we can definitely see something going on right here. It looks to be a through and through defect. So my first question in this case is going to be what kind of guide can we make? Classic guide, obviously, but that would require a second scan. Opti guide requires either a stone model or CEREC data, perfect for something like this, or even a CEREC guide, which would also require a second scan. Um, Now, in evaluation of this, would I seriously consider this for a CEREC guide? And the answer from me is probably no, for a couple of reasons. One, to gain apical extension, we're getting closer to the nerve. And, CEREC guide has a little more fudge factor with it, so I would not be as comfortable there with the CEREC guide. So let's go ahead and take a look, and let's take a look at the implant as it's planned. So here we are with the implant planned. And what I would like to do is say first, this is a pretty good plan, okay? There are a few questions I have. Let's one take a look at the implant plan itself. I think our nerve is marked pretty closely to be inaccurate. If anything, we've erred towards being more superior, which is the error I'd want to make. We have 2 millimeters from the nerve. We don't look like we have a lot of stability in this view, but we have to take a look at all views to determine that. The bigger question I have on this particular case is here is my bone level there. Here is my bone level there. So we'll say it's about like so all the way around. So is this enough depth to accommodate for the bone loss? I have a tendency to believe that this should be pretty close. One thing that I would consider doing in this case is maybe planning this a hair deeper, um, and maybe going with a shorter implant, and going a hair deeper. So we would do something. Let me switch over to I have it as mine. Um, Maybe I would go to a 10 millimeter implant and plan this. Let me just switch back to 11 and a half. I would go a hair deeper, and as we go a bit deeper, now we see that we've extended closer to the nerve. And remember that the drill bit here will look somewhat like that. So the drill bit will actually go about a millimeter beyond the apex of the implant. So in this case, we're getting frighteningly, at least for me, frighteningly close to the nerve. So I would consider going to maybe a shorter implant in this case to allow me to place it deeper. And then if I decided not to go so deep, I could always back the implant out. Um, Now when we look at this view, we can see that we are quite deep. The other issue, the reason I want to plan it deeper in this case is if we take a look at our interproximal bone levels. So, we have some level of unpredictability at where is this bone going to heal. I think it's safe to say that this bone won't heal like that. I think it's safe to say that we'll probably see some healing of the interproximal at that level right there. And then when we have the interproximal at that level, we know that the buccal and lingual will be more like that. So I would, again, tend to plan deeper and then back the implant up if necessary. In other words, once I placed it, if I felt that I was getting too deep to be restorable, and this right here looks too deep to be restorable, but we don't know until the bone heals. So this may be a situation where sometimes we may consider that, you know what, we don't have a lot of room for error in this particular case. Maybe we should take the area out, site graft, and then come back and place in a healed ridge. Personally, I would be comfortable placing this, just knowing that I'm going to have to possibly deviate to it. Now, The next question I have is, this is planned very nicely in the center of the tooth, but in noticing on your CEREC data here, um, one thing that I did notice here, we'll go to clip, is that this particular tooth is lingually rotated. So is our final restoration going to be at this particular position, or is it more ideal to be a little bit more buccal? I don't know. Only you can tell us that. And the reason I bring that up is I would want to plan this tooth based on not where the existing tooth is, but where we would like that final restoration to be. So if we wanted to buckle this final restoration, then we would need to plan the implant a little bit more buccal. But not knowing that, we'll go on the assumption that we're going to put it where it's at. So now everything else looks pretty good. The only other thing I have a concern about here is on this view right here. If we take a look, our occlusal plane is tilted down like so. So I prefer for our occlusal plane to be a little bit more level. So if we take that like so, now we have a more level occlusal plane. And now that's again assuming that this is the level we would like it to be at. Now when we did that, what we ended up doing here was moving this to the distal of the tooth. So we simply slide this over to the mesial about like so. Now when I start doing this, now we can start seeing that we're getting more and more fresh bone here to place this implant into. In fact, if we take a closer look at it, we have 1, 2, 3 threads in fresh bone on the mesial. So it looks pretty good that way. Now, if we take a look at the buccolingual placement, it is based after I've moved it, it's pretty nicely done. Let's go back to the original, and I would say here we're good, but we have a tendency we would have the ability to center this a little bit more like so. So I would prefer to see something along those lines if possible. So all in all, a very good plan, just a few minor tweaks, and that's often what it takes to make the difference. And let's go ahead and check our sleeve, because I did notice that no sleeve was in here, and we want to make sure that this sleeve is outside of the tissue so that we can make sure it seats, make sure it's not hitting any adjacent teeth. And here we are. In this particular case, the tissue looks great. Other nice thing about the sleeve is we can use it to better see how we're centered in the tooth, and in this case we may want to just tilt that back a little bit to the lingual. So hopefully this has helped. Thank you for sending in the case.